Assalamu alaikum. This is the second lecture about the vitamins, fat-soluble vitamins. Started with the vitamin A, what's called retinol. The metabolites or the active metabolites of the retinol or vitamin A in the body, they are retinaldehyde and retinoic acid. And the main function of the vitamin A in the body, the retinaldehyde is important for the vision in the retina or the function of the retina, while the retinoic acid is important for cell growth and differentiation. We have also a third compound, which is a synthetic molecule or synthetic compound called retinoid, which is important for the clinical practice for certain application, like the patient with dermatological disease like acne. So it is used in clinical practice in synthetic form also. It's also play an important role in the immunity to augment the humoral immunity and T-cell immunity and natural killer activity. The main dietary source of the vitamin A is the animal source, which is the liver and the fish, which is excellent source, and also it's present in plant source of plant food, with the dark color vegetable and fruit, especially the carrots. The cause of deficiency, mainly chronic dietary deficiency, can cause isolated vitamin A deficiency, especially in endemic area in this vitamin deficiency. In certain part of the developed country, like in sub-Saharan Africa, Southeast Asia, and in this area it is estimated that 125 million people, especially preschool children, they have some form of the vitamin A deficiency due to decreased dietary intake of food that contain good amount of the vitamin A in this area, and causing a chronic vitamin A deficiency. And the main mortality of those children is due to increased risk of infection, in addition to the other clinical manifestation of vitamin A deficiency. Other cause of the vitamin A deficiency, with the other vitamin deficiency, like patient with the malabsorption, like in celiac disease. Again, alcoholism can cause minor deficiency of vitamin A because of the interference of the conversion of the retinol to retinaldehyde, which is active form in the retina, due to competition of the alcohol on the enzyme dehydrogenase for the metabolism, which is important for metabolism both of alcohol and retinol. Drugs which can interfere with the absorption of vitamin A, like neomycin, which is topically non-absorbed antibiotic like neomycin, in addition to the cholestyramine, which is resin that bind the vitamin A and interrupt its absorption from the intestine. The main clinical manifestation of which is the night blindness due to loss of the dark adaptation at night, which is the early manifestation of the vitamin A deficiency, and in addition to the dryness of the eye, what is called xerophthalmia or conjunctival xerosis. In severe form, the patient may develop white patches of keratinized epithelium on the sclera, and in severe form also there is a softening of the cornea, leading corneal ulceration and necrosis and recurrent infection resulting in corneal scarring. In addition, patients have vitamin A deficiency liable to develop risk of infection, especially GIT and respiratory tract infection. The picture above show indicated by the arrow the beta spot, while the picture below indicated or can show the corneal scarring. Diagnosis depending on the finding of the low retinol level in the blood or vitamin A, and doing the test for dark adaptation is already done by the ophthalmologist, and impression cytology of the conjunctiva by using filter on the lower eye. It causes that decrease the mucus secreting cell and the filter paper on the conjunctiva, and this is also done by the ophthalmologist, which indicate presence of vitamin A deficiency. But the main diagnosis depends on clinical picture and the level of the vitamin A in the blood. Treatment usually replacement started with injectable or oral vitamin A till the improvement. Vitamin A supplement can markedly reduce the risk of child mortality where the deficiency is widely prevalent, as we mentioned before, in the endemic area with the vitamin A deficiency, there is a usual trend to give the vitamin A prophylaxis in preschool children to decrease the risk of infection. Vitamin D, which is the second most important vitamin, fat-soluble vitamin, and it's considered as hormone or steroid hormone. It's important for the mineral iron homeostasis, especially the calcium phosphate. In addition to the presence, the availability in the foods, it can be synthesized in response to ultraviolet light or radiation on the skin by a photochemical cleavage of 7-dehydroxycholesterol. And the main source is the dairy product, or also the animal or the plant source, which is the cereals. And as we know that the vitamin B12, the vitamin D, whether absorbed from the gut or synthesis in the skin by the action of the ultraviolet light, as we have mentioned, and this will pass in, or the vitamin will pass in the first activation of the liver by the function of the enzyme, what's called the 25-hydroxycholecalciferol, and the enzyme will form and the enzyme will cause activation in the liver of the cholecalciferol, forming 25-hydroxycholecalciferol, and this compound was subjected to another activation in the kidney by 1-hydroxycholecalciferol, forming what is called 1,25-hydroxycholecalciferol, which is the most active form of the vitamin D in the body. And this, the active form, cause or induce absorption of the, or acting on the intestine, small intestine, by induction of the absorption of the calcium and the phosphate from the food, and increase in the blood, then laying down of these compound or ion to the bone, so what is called mineralization of the bone. In contrary to the action of the vitamin or the active vitamin D, the parathyroid hormone causing the demineralization, which is pulling the calcium and phosphate from the bone, and it's secreted in the kidney, so it's function on the kidney, while the vitamin D does not act on the kidney, causing the absorption of the calcium on expense of the phosphate, so excreting phosphate, absorption of the calcium, and this occurs in a state of hypocalcemia, and so there is stimulation of the parathyroid hormone to make the level of the calcium stable in the blood, but on the expense of the phosphate. And the parathyroid hormone has a negative feedback on the activation on the level of vitamin D, or the 25-hydroxycholecalciferol. Cause of the vitamin deficiency, either impairment vitamin D deficiency in the food, or impairment of production, like impaired cutaneous production due to decreased exposure to the sunlight, and decreased dietary vitamin D, like patient have a little dairy product, or in intestinal disease like in malabsorption with other vitamin deficiency, or there is an accelerated loss of the vitamin, like using drugs that induce or hepatic enzyme inducer or activator that accelerate the vitamin D deficiency, like barbiturate, phenytoin, rifampicin, or in patients who have impaired the enterohepatic circulation interrupted, like the patient have chronic cholestasis, there will be decrease the pull of the bile, which is important for micelle formation and absorption, and because of the vitamin D is depending on the fat absorption, there will be vitamin D absorption failure. The main clinical manifestation is osteomalacia in adult and rickets in childhood, and sometimes it could be asymptomatic deficiency without clinical manifestations, only detected on the lab check. And the osteomalacia, which means defective bone mineralization, usually presented with their bone pain and malaise, and sometimes they present to proximal neuropathy, make the patient go to the waddling gait, and patient also may develop fragility fracture, which is mean that without trauma or significant trauma due to development of a pseudo fracture. And on examination, we can elicit bone tenderness due to vitamin deficiency. In children, as we mentioned, patients usually not develop fracture, but develop growth retardation and bone deformity. And the picture can show the loser zone, what's called pseudofracture, which is mean that the partial fracture. Normally, the fracture due to trauma is occurred by started from one cortex of the bone, traversing to the opposing cortex. This is called a fracture. But if it is does not transfer from one to other cortex, this is called a pseudofracture or a loser zone. Usually occur in the pubic rami and the femoral neck, femoral neck and the upper femur. We can elicit this fracture in the upper femur also. The diagnosis of vitamin deficiency is depending on the biochemical test. We can show decrease the serum vitamin D and low or normal calcium due to compensatory mechanism by increased parathyroid hormone, but the phosphate usually low in the vitamin D deficiency. In addition, there is a compensatory increased parathyroid hormone with increased alkaline phosphatase due to increased bone demineralization. We have also radiological tests for the diagnosed vitamin D deficiency. There is a global decrease in the cortical thickness and the diffuse osteopenia of the skeleton, which is decrease the density of the bone in X-ray and cause what's called Gauss vertebra, or which the density of the vertebra equal to the surrounding abdominal density, which is the abnormal, and development of the pseudofracture, as we mentioned that before. Replacement usually is the mainstay of treatment. The main mode of treatment by placement of high dose 50,000 international units from 3 to 12 weeks, weekly injection or weekly oral ampoule, and followed by maintenance dose of prophylactic dose of vitamin D, which is 800 international daily. Would encourage the patient to take calcium daily in a dose of 1.5 to 2 grams per day. Vitamin E, what is called tocopherols, is acting in an antioxidant and radical scavenger, which protect low density lipoprotein and saturated fat in the membrane from oxidation. And as we know, because of the metabolism, there is excess oxidant coming from the cell. So the vitamin E is made as an antioxidant for these to protect the cell from death. The main source, it's widely distributed in the food, so isolated deficiency is extremely rare in clinical practice, and it's usually present in high level, high dose in sunflower and soybeans and corn oil, and also in the nuts and cereals grain, and it's also present in small amount of fruit and vegetables. The main deficiency cause of the vitamin E is prolonged malabsorption disease with other vitamin and prolonged cholestasis, because as we mentioned in slide before, is depend on the fat absorption. So the dietary deficiency, because presence in all food stuff, dietary deficiency does not exist, or isolated dietary deficiency does not exist. The main clinical feature is due to axonal degeneration of large myelinating axon, specifically the posterior column. So the patient developed peripheral neuropathy and sensory ataxia due to involvement of the posterior column of spinal cord, in addition to the ophthalmoplegia. Main mode of treatment is replacement and a dose of 800 to 1,200 milligram tocopherol per day till the improvement of condition of patient. Vitamin K existing in 3 compounds in the clinical practice: vitamin K1, which is called phytoquinone, which is present in the food, and vitamin K2, which is aminoquinone, which is synthesized by the bacterial flora in the intestine and present in good amount in hepatic tissue in the liver, and vitamin K3, which is called minidoin, which is that synthetic form, presence in ampoule. Vitamin K is important for the synthesis of the coagulation factor in the liver, which is factor 2, factor 7, and factor 10 and 9, in addition to the factor or protein C and S. The main source of the vitamin K is the green leafy vegetables. In addition to it is available in good amount in the liver. The main cause of vitamin deficiency is small intestinal disease like celiac disease, or malabsorption due to celiac disease, coronary cholestasis. In addition to the broad spectrum use that may suppress the bacterial flora and trap the synthesis of the vitamin K from the normal comments or normal flora in the intestine. In addition to the drugs that interfere with the fat absorption, like anti-obesity drug or lystatin, that cause the fat malabsorption, causing failure of absorption of the vitamin K with the fat. The diagnosis usually by elevated coagulation profile like prothrombin time due to vitamin K deficiency. In addition, vitamin K can be measured, calculated directly in the serum. Main way of treatment is the replacement of the vitamin K instead of ampoule or in the form of the ampoule by parenteral injection IN, 10 milligram ampoule, until the improvement of coagulation profile and the clinical situation of the. Thank you very much.